This is our last session. We have an hour and a half, and we're changing our focus to influenza and pneumococcal disease. And in a sense, we're covering what we often cover in a day and a half, in an hour and a half. We have 4 very dynamic experts who will be able to cover this. And our first is Professor Bill Rawlinson. Bill's Director of Virology at the Southeastern Sydney and Illawarra Health Services. And Bill's going to talk about the differences between COVID and influenza. Bill, thanks.
So thank you very much, Lou. As Lou said, we are going to talk about influenza, but of course in 2021 you can't talk about respiratory viruses and not talk about SARS. And so my topic is to look at the differences between them, and it's actually quite instructive, and it's very interesting when you do look. This is a quote from P.G. Wodehouse, who of course wrote the Jeeves and Worcester stories, but I thought that it was very apt. It was from 1926, but what it says is that the way that it's quite amazing the way that we adjust ourselves to conditions which seem intolerable at the start. And of course, in many ways, wearing masks, not traveling overseas, the things that we're doing now are something that we've just come to expect. And in going forward, I think one of the key messages is that it's not going to be the same as it is now. I thought the way I'd address this topic is to talk about 4 major areas: about case definitions, a bit about the clinical presentation, not much about the epidemiology because I think you get a lot of that, and a little bit about the virology, because as a virologist, I see what is arising clinically as a direct consequence of the nature of the virus and the way it replicates. And for example, the mutational issues that is occurring currently with variants of concern. And finally, a little bit about outcomes and a bit of a summary. We're calling it a pandemic, but I always love these definitions because they're so broad. A pandemic's an epidemic that occurs worldwide. There have been things like every continent, numbers, but the reality is that in some ways we reach a pandemic threshold for influenza in a busy year, although we talk about it as epidemic influenza. Case definitions are interesting, and I don't expect you to read all of this. There's a lot of words, but I'm going to summarise them as I go through because it's very instructive, I think. And these are from the Public Health Laboratory Network, the PHLN, which I belong to, and which provides national definitions and which we often use in outbreaks. This is one from 7 years ago, which is an updated SARS, what we'd now call SARS-CoV-1. And the interesting thing is it's very laboratory based. It's based around seroconversion or virus isolation, or and most commonly a positive nucleic acid test. When we look at SARS-CoV-2 definition, it's, as you can see, firstly a bit longer. But if you look at the suspect case, which is at the top right of this slide, it's really very much a quite broad definition, and something which is of interest is that increasingly in my practice as running a reference diagnostic laboratory, we see a lot of people who have very few of these criteria, and it's simply on the basis of testing. So again, as with SARS-CoV-1, we're now seeing a lot of people diagnosed who are asymptomatic and who are tested for other reasons, particularly, of course, those who have appropriate epidemiological criteria, and in Australia, particularly those who've returned from overseas and are in quarantine. And so the clinical diagnosis of SARS is problematic because it's really, to some extent, been replaced in my practice and in many people's practice by a laboratory definition. On the other hand, we have a lot of experience with influenza case definitions. Again, this is from the Public Health Laboratory Network from last year. And again, this was updated quite recently because of the current pandemic. And we actually have ideas about sensitivity and specificity. We know how well the influenza case definition works during epidemic times and outside of that. And it does have a high sensitivity, but it depending upon which criteria you use, it has quite a low specificity, and that specificity becomes almost useless in many ways once you're outside the epidemic time period. So again, influenza often based around laboratory testing. I'm not going to go into epidemiology. I'm going to focus a bit more on the clinical presentation, but this is a virologist view of epidemiology. We know about the yearly epidemics of influenza, and we have a lot of information from monitoring methods that are around general practices, around laboratory surveillance, around emergency departments, and there are specific projects like Flu Tracker, which have been used to follow influenza as well as other respiratory viruses. And we have a fairly well-defined script for the affected populations. If you look at coronaviruses broadly, so the 4 coronaviruses that are epidemic, and that's NL63, OC43, 229E and HKU1, not MERS, SARS and SARS-CoV-2. These are quite well-established infections. There are recurrent outbreaks. They tend to be more in winter. They tend to be associated with children as well as sort of at-risk individuals. It's interesting that HKU1, which is one of the 2 beta coronaviruses apart from the SARS and MERS, was only found 16 years ago. And it's likely that OC43, which is probably the best model we have for SARS-CoV-2, really only became established in the population a bit over 120 years ago. And in fact, may have been one of the causes of the 1899-1900 pandemic of what was regarded as influenza, but it may have been the first presentation of this beta coronavirus. And the reason I dwell on this a bit is because this would be the model for SARS-CoV-2 to become established as a recurrent respiratory infection, which is within the population and recurs every year. Of course, you're all aware of the recent pandemic, the importance of asymptomatic infection, asymptomatic spread, and the really interesting observation that children do not seem to be as severely affected by SARS-CoV-2. So the clinical presentation, this is a slide taken, I think, from the CDC or WHO website. This just puts influenza alongside COVID-19 in very broad terms. And basically what we're looking at for SARS-CoV-2 is a higher naught number, that is a higher number of individuals infected from a known infected individual. This varies in different populations and under different conditions, but it's likely somewhere between 2 and 3 compared to influenza, which has been quite well measured at 1.27. The incubation time is fascinating because, of course, we typically think of SARS-CoV-2 as having an incubation of up to 14 days, but in fact we have seen infections at over that time. We're currently dealing with one of these in New South Wales at the moment, or a possible one of these. Whereas incubation time for flu is typically less than 4 days. Typically for COVID-19, the median's about 5 days. Hospitalisation currently much higher for COVID-19 and case fatality logarithmically higher for COVID-19 than for influenza. Of course, there are other respiratory infections, and coronaviruses generally, the 4 that I've mentioned, cause about 1 in 8 infections. They're shown there, but also other things like measles and other viruses cause respiratory infections. And we still have MERS with us, although it hasn't emerged as a pandemic virus. It's predominantly a zoonotic virus from camels to humans. And of course, the last case of SARS-CoV-1 was in 2004 as a hospital-acquired infection. And this just shows, these are Australian data from Stephen Lambert and from about 14 years ago, but they're quite relevant. And basically a very high peak of influenza in July, August, September, typically a slightly broader NL63 human coronavirus somewhere between May and November. And the current question is whether SARS-CoV-2 will only be a winter disease or not. Just a comparison of presentation, they're both respiratory spread. There does appear to be aerosol spread of COVID-19 from some experiments, although it is currently not thought to be as high as for influenza. Typical presentations with respiratory symptoms of fever, although again, COVID-19 with more frequent severe illness and more frequent mortality, and also a large number of asymptomatic infections and similar complications. The really interesting thing is that's emerging and is not unexpected is that with COVID-19, it does appear that inflammation in the respiratory tract as well as in other organs, particularly in the neurological system and within the cardiovascular system, is much more severe and may well be associated with a higher mortality. And there's a very nice review of inflammatory cardiac disease from last year from Carn, which basically shows that if you have myocarditis, you have a much higher risk of death, and that if you look at, conversely, if you look at people who die, more of them have had myocarditis. And also other intravascular problems from COVID-19, such as clotting with pulmonary thromboembolism, as well as neurological clotting with large vessel disease resulting in stroke, hemorrhagic as well as ischemic stroke, as well as inflammatory conditions of the CNS with encephalitis, seizures which may, if investigated, are usually associated with some form of encephalitis. And interestingly, these loss of smell, loss of taste syndromes that may precede other more severe disease. Interestingly, a paper from some time ago looked at pandemic influenza and saw more severe complications and mortality much higher in the group with pandemic, the 2009 H1N1 strain. And it sort of broadly in pathogenetic terms suggests that a new virus is more associated with more inflammation. And if you look at the 1918 so-called Spanish flu outbreak, again, major inflammatory change was associated with human contact with this new virus. And so it may well be that that's the nature of a new antigen being presented, as well as potentially the virus itself, that results in this more highly inflammatory condition and hence more severe illness. Of course, influenza are associated with neurological syndromes like encephalitis, Guillain-Barré and cerebellar ataxia. If you look at the characteristics of hospitalised patients, and this is specifically about hospitalised patients, and those who get into hospital with COVID-19 are typically overweight, may have diabetes, hypertension and dyslipidemia. Whether all of these are related or whether, for example, they're associated with each other is still uncertain. But compare that with influenza, where the classic groups that we warn about each year who are at risk of influenza, such as those with chronic cardiac and respiratory disease, those with chronic liver disease, are associated with worse outcomes. COVID-19 having more respiratory failure, pulmonary thromboembolism and stroke compared with influenza, where the predominant manifestation of cardiac effects, and I won't say involvement, rather effects, is acute myocardial infarction and atrial fibrillation. Similar median ages of those who are hospitalised with COVID-19 influenza, possibly because these conditions are associated with ageing. Mortality, as I mentioned, higher with SARS-CoV-2, COVID-19, particularly if you're older, particularly male, although men and women die from COVID-19. Chronic cardiac disease, and there are some biomarkers which were mentioned earlier in the talks today about immunology, such as IL-6 and D-dimer, which are probably inflammatory associated, that are associated with a worse outcome. Influenza, mortality varies between studies enormously. Again, much higher apparently with the pandemic, this association with underlying disease has recently been brought into some doubt by papers. There's a paper from a couple of years ago by Harris where there was not such a clear association. And this just looks at the effects of age. And really this age between 0 and 65 plus on the bottom axis, and percentage mortality. In red, COVID-19, always higher than the yellow, which is influenza, but both of them go up with increasing age, particularly once you hit 65. I mentioned cardiovascular complications, and I thought this is important to talk about because of the association of this with death. In somewhere between 1 in 7 and up to 3 in 4, patients with COVID-19 who die have an underlying cardiovascular condition. And as I mentioned, higher, in this group particularly, higher rates of clotting conditions such as deep venous thrombosis and pulmonary thromboembolism. It's interesting that during the pandemic, there's been reduced cardiac hospitalisation for other conditions, and this is thought not to be due to an effect of the virus, but to simply an effect of deferred admission. Influenza, much lower case fatality, and there is an excess cardiac mortality, possibly associated with inflammation, but also possibly associated with cardiac load. Vascular thrombosis, in contrast, of course, is quite uncommon, although it does occur typically as a complication of admission rather than the underlying influenza itself. Of course, the other thing that COVID-19 has brought us has been a whole lot of black humour. And for those of you who've read your children or enjoyed Where's Wally or Where's Waldo, depending upon which part of the world you're in, this is the social distancing edition. So a bit about the virology. I'm not going to talk a lot about this in the last couple of minutes, but just to contrast the influenza strains, the subtypes that we know, was with SARS-CoV-2, we talk about lineages and the emerging variants, which are based upon a lineage rather than a single mutation, although there's been a lot of focus, for example, on the E484K mutation, which is associated with the so-called South African or B.1.351 strain, as well as the B.1.17 UK strain, which of course are now spread internationally. They're similar viruses, although they look different, as I showed at the start. SARS-CoV-2 being positive, influenza being negative stranded, they're both enveloped. And as I mentioned, they have different surface proteins, and these genes tend to define some of the targets for vaccines and other things. These are just a couple of cartoons, different binding sites. As you all know, I'm sure, SARS-CoV-2 binds to the ACE2 receptor, which is a cardiac receptor, but spread throughout the body. It requires an enzyme to be activated, whereas influenza binds to the terminal salic residues of different types of proteins in humans and birds. And it's thought that shuffling of these targets is what allows spread between avian and human strains. So briefly, just to point out that we now know a lot about the genomics of SARS-CoV-2, and that increasingly we are now tracking lineages, and there are literally hundreds of thousands of sequences available. We know that the viruses we're now seeing diverged quite some time ago from animals to humans, although in relative terms compared to, say, the herpes viruses, which diverged hundreds of thousands of years ago. These are relatively recent divergences. So in circulating flu and SARS during winter, we enhanced our testing. How do we distinguish them? They're very difficult to distinguish on the basis of their clinical presentation, but of course it's extremely important in thinking about therapy. For it, just as a simple example, we do have some antivirals that are effective for flu, but we don't for SARS. We do use steroids for SARS because of the inflammatory components. We don't for flu. Co-infection, variable studies. We've recently published our experience where 2% of Australians were infected with flu and SARS, another 6% co-infected with rhinovirus and SARS, and that's about the emerging picture. So I'm over time now, so I'll finish. Just to say, Fred Sanger got the Nobel Prize twice, so we listened to him. It is important that what we're doing makes a difference, and these are the people who help us to make a difference, and thank you for your attention.
Bill, Thank you. Terrific. Our next speaker is going to address the topic of influenza epidemiology, and who better than Professor Ian Barr. Ian's the Deputy Director of the WHO Collaborating Centre in Melbourne, and Ian's been giving this talk for many years, and Ian, this meeting would not be true without you contributing, so thank you.
Okay, thank you very much, Lou. Hopefully everybody can see my screen now. And thank you to the 151 participants who have stayed on for a little bit of influenza in amongst an awful lot of COVID. So it's a little bit more expansive than the title. So instead of flu epidemiology, I'm going to give you a bit of a rundown on the 2020 season. And you'll see there in the heading, I've got season in inverted commas because we didn't actually have one. So I put this slide up last year at when we were all getting together and having a chat, and what a year! It makes a difference, doesn't it? So certainly, coronavirus has certainly outdone influenza in this year. So this is a normal slide I put up, and I have a show of hands. I don't think there'll be any discussion this year. We've got a new category, and that's a COVID-19 impacted season, where there is little or no influenza. So I think this will be a new benchmark for influenza seasons, the lowest of the low. So just to give a bit of a summary though, what actually did happen, and these are some of the usual measures which we use to determine our seasonality of influenza in Australia, and that's the NNDSS numbers, which are followed quite closely by the ISG and by the press. And you'll be pleased to know that it was the lowest detection since 2009. Pandemic, when figures started to get a bit better than the rubbery versions beforehand. So it's the lowest since 2010, in fact. In 2020, only 6.8% of the cases were reported of 2019, where we had a very big year, so 21,000 versus 313,000. And as you're probably well aware, 94% of the cases were reported in the out-of-season period between January and March in 2020. In terms of the aspirin data, the influenza-like illness had a slightly above average for January and March, and I'll show you that shortly, and then it flatlined. And similarly with flu tracking. Other characteristics of the season, what we saw from the viruses which we analysed here at the centre is that they were mainly influenza A viruses, and they were mainly H1 pandemic viruses with a few H3s and a few B Vics, virtually no B Amigato lineage viruses circulating. That might be one good thing out of the pandemic, that with a bit of luck, we might get rid of B Amigato viruses. And FluCan data virtually flatlined, so there was only 15 hospital admissions from late March to late November 2020. Deaths, again, very low, only 37 in 2020 compared to 902 in 2019, and again, the elderly most affected, as you would expect. So just run through a few graphs here, and if you just focus on the baseline, that's where you'll find most of the 2020 curves. So here's the influenza-like illness curve here, running on the baseline. The lab confirmed data for 2015 to 2020, again, the red line here, and you can see that slight above average levels there in January to March. And as soon as restrictions were brought in on travel and international admissions into Australia, that dropped off and has been flatlining ever since, and is still flatlining. That was the case across all states here, and you can see that there are a few lumps and bumps in some of the states here where they have reported cases of influenza. We've got some of those cases, or some of those samples have been submitted to our centre. We can't confirm influenza in those, so it's either a very low level of influenza in those particular cases, or they're false positives, which is what we suspect. In terms of what types of influenza, I've shown you this, but I just want to put this up to remind people that where possible, we would like to get more subtyping data, and clearly when people are busy with COVID-19, that probably hasn't been possible, but going forward, you can see here the overall figures for Australia is around 80% of labs are now just doing influenza A or B and not doing any subtyping, so we would encourage labs where they can do some subtyping to contribute to the overall understanding of the different influenza A subtypes, and B, if they're really keen, lineages. So FluCan, as I said, didn't really get going until the end of March, so a little earlier than usual, but flatlined throughout 2020. Here's the death data, and just as I said in the summary slide there, only 37 deaths with a fatality rate of 0.17 overall. So again, both figures much lower than we've seen in the last 5 or 6 years. New Zealand run this funny dashboard now. They've seen virtually no influenza throughout 2020. Clearly, some of the COVID data might have got into their systems here for ILI. So some of those bumps are probably COVID worried people, or maybe rhinoviruses, which have circulated in New Zealand. But you can see the grey curve there in the bottom panel there is what we'd normally expect, and certainly they're well down on ILI. And as I said, there've been no confirmed cases of influenza that have gone through the laboratories in New Zealand since March 2020. So it's been a quiet year for human influenza in Australia, but it's been a busy one for avian influenza in Victoria. So some of you who read the Weekly Times, which I'm sure everybody does, might have seen some of these stories. It's also appeared across the general media on the ABC News that there were a number of outbreaks in Victoria around the July-August period. So that involved a large number of birds being affected. There were 3 different viruses which were being detected, and amongst that, those outbreaks, there was a high path avian influenza H7N7, and high path means that it usually kills 99 to 100% of birds within a couple of days. There was a low path H5N2 virus in turkeys detected as a result of these H7N7 investigations, and there was also another low path virus detected in emus, H7N6 virus. So here's where they occurred. So they occurred in Kerrang, which is in the northwest part of Victoria, Lethbridge, which is just an area just outside Geelong, and that's where things started. So we had H7N7 at 3 different farms there, and in an adjacent farm, a turkey H5N2. And that turkey farm also took some turkeys for a holiday to Bairnsdale, and the virus was detected in turkeys at Bairnsdale as well, H5N2. So here's just a summary of the outbreaks. So they occurred between July and August. 3 different strains, as I've said, across 6 farms in Victoria. 3 of the farms had the H7N7, the highly pathogenic one, which is death to most chickens. 2 turkey farms had low pathogenic H5N2, so they might get a bit sick or have minor conditions, but doesn't kill them. 1 emu farm had H7N6 low path, which doesn't seem to affect the adult birds very much, but can have a pathogenic effect in young emus, and can lead to some death. So overall, over 460,000 birds were culled. Most of those were chickens, but some turkeys and some emus. And apparently this emu farm is the #1 breeding place for emus in Australia. So it involved a huge cleanup operation from humans, involving many weeks with dozens of workers. There was no confirmed human influenza infections with any of the avian influenza viruses that was confirmed. One thing the outbreaks did identify was some problems with the whole One Health concept, and many of you have heard about One Health and some of its aspirations, but it's just not working, to put it bluntly. So the initial H7 outbreak, I noticed on a ProMed posting rather than any communications from the veterinary groups, which is totally unsatisfactory. And in fact, when we requested viruses from the animal health laboratories at Geelong, we were told that was unable to get them because of some legislative measure. And here we are 6.5 months on, and we're still trying to resolve that. So some work to be done with the One Health situation. So these are relatively rare, these avian influenza outbreaks, but they have happened before, but to a lesser extent. So I put down a listing of the 3 most recent outbreaks there. One was in Bendigo, which was a H7N3, high path, 17,000 chickens, and then a couple in New South Wales. Again, H7, which is the only high path virus which has been detected in Australia to date. So back to humans, what's happening with other respiratory viruses during 2020? And this is a really informative page which is put out by the New South Wales Department of Health, and this shows tracking of respiratory viruses with pretty much real time, a couple of weeks behind. So we've seen the top 2 panels there are influenza, and we've seen no influenza post-April. You can see the flat lines there continuing, and you can see here for some of the other viruses here, parainfluenza has had no activity. RSV, this panel here, you can see here that there's been a big uptick here from October onwards, and that outbreak is still ongoing. And there's also a similar peak now been occurring in Western Australia a little bit later from November. That's still going as well. Adenoviruses, I missed that one. Adenoviruses have circulated quite widely, as well as rhinoviruses. Virtually no human metapneumoviruses and very low levels of enteroviruses. So I think that's a very useful page, and keep an eye on the different respiratory viruses. So I'm sure flu will make its comeback. I don't think we'll see it for a while, but certainly RSV is on its way back big time in at least 2 states in Australia. So just swapping back to influenza for a minute, and I know Gary Grohmann will go over this in detail, but this is some of the changes for the influenza vaccine for 2021. So there's 2 changes there. The H1 component and the H3 components are both changed from the 2020 vaccine. The B components remain the same. In terms of what's available, and again, Gary will go through this, so I won't dwell on this, just to say that we do have 1 new entrant for 2021, and that's a quadrivalent inactivated cell-based vaccine. So I think that's been quite a while coming to Australia. Unfortunately, I think we're still waiting for LIOV. I'm not sure when that's coming. And I think we're still waiting for the recombinant protein-based vaccines, such as the one produced by Protein Sciences, which is based on a recombinant hemagglutinin protein. And as far as I understand it, we're not getting any high-dose quadrivalent vaccine this year. But maybe the people of Sanofi can confirm or deny that particular situation. So I think Paul Effler and Paul Griffith have already raised this, so I won't go into this in any detail, but clearly there's going to be overlap between influenza and the SARS corona vaccinations in 2021. And the recommendations from ATAGI are to have a gap of at least 14 days between any of the vaccinations. So I think that's going to become quite tricky. And convincing people that they need to go along 2 or 3 times within a short period of time will have some challenge, I think. So just to give you a little bit of an update of what's happened since our season or non-season in 2020, what's happening in the Northern Hemisphere so far, not much. So here is a WHO plan of attack of what's going on with influenza. And I'll show you the next slide just to show you, highlight what's the difference between 2020 and 2021. So the yellowy colors there show the incidence of influenza positive cases across the world. And you can see that last year there was lots of different colors of yellow from light to dark, whereas this year there's virtually no parts of the world which have anything apart from the lightest of yellow, which is a positive influenza rate of 0 to 10%, and it's closer to 0 than 10%, I can assure you. So there have been viruses turned up, a very small number in North America, a very small number in Europe, and nearly all influenza B viruses in China, shown here by the brown pie chart. So very little activity happening out there, and this is shown here in another plot from WHO, which shows the influenza types and subtypes, which have been circulating since last year. And you can see here's the normal sort of numbers which you would have in a winter season here, with some 50,000 specimens being processed by the GISRIS network. And here we are at this time of year, somewhere up about here, a bit further on here. You can see I've blown this up here so that you can see the axis here, and you can see there are very, very, very few numbers of viruses which have been detected. And most of those have been the bees which have been reported out of China. Just to reiterate that, there's some data from the CDC website. This is their weekly flu update here, and you can see green is good. That means minimal or no influenza. And you can see here their ILI data here in the top right panel. You can see here well below their normal threshold of 2.4 or 2.5%, where they say that influenza is circulating. Again, number of tests positive, very, very low in the dozens or handfuls, and number of deaths. I think there's only been a single death attributed to influenza. in the pediatric population under 18, shown in the bottom right-hand panel there, and you can see that compares to hundreds of deaths in previous years. What's happening in Europe and the UK? Again, very little activity. It's only sporadic. A few cases here and there, and virtually no outbreaks occurring currently. So where has there been recent influenza activity? Well, I've already mentioned China, and that's shown here in the bottom curve here, but you can see that there's tiny little additions here on the x-axis compared to normal activity in winter. The only other places we've seen influenza have been in Western Africa, and you can see here Cote d'Ivoire have been getting viruses of H1 and Bs. In Cambodia, there was a fairly large outbreak of H3 towards the end of 2020, but that's now receded. And Bangladesh also saw a small outbreak of H3 at the end of 2020, but really nothing compared to their normal outbreaks. So very little activity going on globally. So in summary, a record number of vaccines, which I didn't mention, was distributed in Australia in 2020, some 15.7 million doses, about 9 point something to the government and 6 point something to the private sector. Enough to vaccinate 63% of the population if it all went out into arms, which I suspect it didn't. 2020 was an historically low influenza season in Australia, even lower in New Zealand. My goodness, these people are persistent. Influenza H1N1 predominated in Australia, but very few cases after April 2020. The vaccine match, probably a little bit hard to say. There's so few viruses for us to do a good analysis. In terms of oseltamivir and zanamivir and baloxavir resistance, we didn't see virtually none. Hospital admissions were low, as I'd said. VE, vaccine effectiveness, too few viruses post-vaccination to calculate anything. So the dramatic effect on many respiratory viruses was seen due to the COVID-19 non-pharmaceutical measures which were used. Rhinoviruses and adeno still circulating, and RSV's on the comeback, and flu will be there one day. So influenza activity in the Northern Hemisphere is at record lows, as it is in the US, EU, Japan, and China. We've updated 2 components of the 2021 vaccine. I think there's going to be quite a challenge for people to get around and get vaccinated. I'm sure the word will be around that influenza is not circulating or very low level circulation, and everybody will be clamoring for the COVID-19 vaccine, not for the influenza vaccine. So I think there's quite a job there to be done to try and keep vaccination rates up, because you just never know when influenza will be back, probably as soon as they open borders. So I've made these wild predictions every couple of years. So how did I go last year? I predicted a quiet year with H1, so I'm going to give myself 2 ticks there. I didn't say very, very, very quiet, which would have been more correct. My prediction is for 2021 that it'll still be a very quiet year. Until we open international borders, I don't think we're going to have a risk of major outbreaks, but you never know. So I suspect a quiet year with H3 viruses predominating. And maybe we can learn a lot from these measures we've taken for COVID-19 to help us with future outbreaks in influenza. Thank you. And here's where I get all the data from. Thanks.
Ian, thank you. As always, a fabulous presentation. Now, the next talk is on new vaccines, and this is being addressed by Gary Grohmann. And Gary's a virologist who's ideally placed to give this talk, having had a lot of experience in evaluating new vaccines in appointments with the TGA and on a number of WHO committees. So Gary, thank you.
Thanks very much, Lou. So I've been asked to speak on egg versus cell-based influenza vaccines. And in that sense, it's a new vaccine. So as you probably all know, Seqirus have brought out Flucelvax, and that's been registered in Australia, although it has been registered overseas before. And I'd like to, from the outset, just to thank Jonathan Anderson in particular and Seqirus, who gave a wonderful presentation to the IC a little while ago. And I've asked you some of the slides from that slide deck, as it just seemed to make sense, as they are the only manufacturer that have successfully made and promulgated a cell culture flu vaccine. So I'd like to thank them for that. So as a quick outline, That's it, right. So as a quick outline, I just want to talk about what the problem actually is and why people are now moving towards cell. Look at some of the current vaccines available, Flucelvax itself, and then a few conclusions. So we know that antigenic drift affects VE, and for flu vaccine, many efforts have been made to try and redress the other part of the problem, which seems to be egg-adapted changes, because we're using egg seeds and egg vaccines. Now, obviously, we can't do anything about drift, but manufacturers and researchers have tried to do a great deal about egg adaptation. And we managed to then have cell seeds, some of those being transferred into eggs. And now we, with Flucelvax, we have cell seeds and cell culture. But even though this work has been going on, there actually haven't been any definitive studies they can hang your hat on, at least, for the advantages of cell versus egg vaccines, but I'm sure those studies will come. But there has been some work to show that there is a difference in VE between egg and cell vaccines, and this can actually vary between seasons, particularly for the age 3 group. And that's where I think personally that cell-based vaccines will give a great advantage to the community in terms of VE. There are also differences between age groups. There are some other issues, though, worth mentioning. Egg allergy, as we know, is an issue for some people. Egg supply can be an issue for manufacturers. Vaccine strain selection can be an issue. See, if it's egg supply, then the vaccine strain selection has to be quite early, some 9 months before vaccine production. But with cells, then it probably can be shortened. And that's another advantage of cell-based vaccines. We might be able to get more accurate strain selection when it comes to flu vaccine. And then, of course, vaccine production. Well, that's an issue for both of them. And it's probably a little more complex in terms of quality, and having PC3 and so on in the production of cell culture vaccine is quite important. So this slide from Gizris Network, a paper by Ian Barr. Now, it's data from way back in 2013 or so, 12-13 season, but it is an important slide because it just shows the difference between these egg-derived vaccine viruses and cell-derived on an antigenic map. And you can see with the egg-derived ones, which are often selected because of their growth characteristics and simply availability sometimes, are here, and not necessarily perhaps in the middle where they should be, to try and have as much cross protection to the other strains, other wild type strains. But the cell-derived ones here in pink and red do much better. So this is just for the age 3. And as I said, over the years, as people are looking at this data, it seems to benefit the age 3s more than any of the other virus types for flu. Slide from Seqirus, which just simply summarizes the issue quite well. I think that the egg-based process, going from isolation right through to formulation and filling, the strains are selected and then they have to be made in eggs. Strains have to be made in eggs and then harvested, and there's this potential for egg adaptation while the seeds are being made and also in manufacture. But for the mammalian cells, if the seeds are made there and then put into mammalian cells, then you obviously don't have that issue. So the world has been striving for a long time for better production technologies, and I've shown this slide over the years. Lots of different technologies have been tried. Eggs we know about, cells are here now. Recombinant protein is also here, but not in Australia. Expression through plants or fungi or whatever it might be. And of course now nucleic acid vaccines as well via COVID. This may well spill over into flu. We'll just have to see. And the goal, of course, of this development of technology is that it will address various unmet needs. And the other thing is we need a variety of technologies if we're going to supply the world with vaccine. And that comes really from a WHO point of view, trying to ensure that low and middle income countries also get supply. And at the same time, we've had we've been striving for better vaccines. So yes, at the moment we've got strain-specific vaccines with not very good efficacy. Sometimes we have type-specific, multi-type, multi-subtype would be the next level of that. Then a pan group, maybe looking after group 1 or group 2, and the holy grail is universal vaccine. We haven't seen a lot of information on this development, except in fact for the cell culture vaccine, which will give seemingly better vaccine effectiveness, at least for the H3 strands. So just a reminder that vaccine manufacturing is a long and complex process, and we get very involved with the R&D and regulatory approval. Well, that's just the beginning of it. Then after that, the manufacturers have this constant process that's going on, which is, depending on the process, always peppered with various control and quality control data points here, which then get shared with the regulator. And there's symbiosis, if you like, when it comes to quality control between the manufacturer and the regulator to ensure the highest quality from this R&D onwards down to filling and then distribution. So from WHO, who are more concerned about production capacity, the global capacity in procurement of vaccines for low and middle income countries has been a concern for a long time. And this couple of papers here, and the latest one from Erin Sparrow, has just broken down production capacities to seasonal and pandemic. And if you look at the seasonal, sorry, my screen's a bit blocked by something, I'm not sure why, but you can see there's 1.48 billion doses approximately of seasonal vaccine available. And can somebody reverse that? I can't seem, it doesn't seem to work on my system here. Anyway, maybe it's not that important. The important point was with that there's about 1.48 seasonal vaccine available, and nearly all of it, as you can see on this slide, is produced in Western countries, plus Russia and China and India. Very little of it is produced in Africa, none in fact. And it's the big pharma, as we call them, that are producing most of the seasonal, and therefore they have the capacity for pandemic vaccine. It's estimated now that about 4 billion doses of pandemic vaccine could be made by the same companies that are producing seasonal vaccine, all being well. And that would be a medium case scenario. The best case scenario is probably between about 6 and 8 billion, but I think that's really pushing it. But if 4 billion could be produced during an influenza pandemic within a year or two, given current technologies of egg and cell and the recombinants, then that would be an extraordinary boost. But developing countries do have a dilemma. Influenza is just simply not a priority for them when it comes to influenza vaccines. And I know this having worked for WHO and gone to many developing countries who wanted to manufacture influenza vaccine, and they may well produce other vaccines, but influenza is very low on the list. And part of the reason for that is there's simply no demand for seasonal vaccines. Investment is an issue, even though a lot of it does come from various foundations and government. They have a very large population, much larger than in the West in general. They have a lack of technology, and they have other vaccine priorities. They'd much rather put their money into other infectious diseases. So there's some of the dilemmas for developing countries who are considering the development of pandemic vaccine. And perhaps the greatest dilemma is that to produce pandemic vaccine, you have to have good seasonal manufacture to ensure quality and safety and so on. And they just simply don't have this in their infrastructure. So what are the available vaccines? So I've taken this from the European and American suppliers, and they're more or less the same, except Europe has some others under a different name. And the point of the slide is, yes, we see the main manufacturers, Seqirus, GSK, Sanofi, being the three big ones, if you like. But as you can see there, and you'll see on the next slide too, the platforms are all egg, except for Flucelvax, which is cell, and the Flublok, which is recombinant. And we see with FluMist, Fluzone, Fluad as well, quadrivalent, trivalent, also egg-based platforms. In Australia, we see Sanofi supplying GSK, Mylan Health supplying Influvac, and Seqirus, and this is what we saw last year. And this year we will also see the Seqirus Flucelvax quadrivalent for the first time for adults and children over the age of 9. So let's look at Flucelvax briefly. It was first licensed in 2016 and over 100 million doses have been distributed worldwide. It's now available in Australia for 2021. It's a subunit vaccine with HA and NA and propagated in MDCK cells. It was first licensed really under the Novartis banner back in 2012. And the history of cell culture vaccine prior to that, there were a few groups like Baxter, for example, that did try cell culture. They had Vero cells and they had a few problems, but they did manage to successfully make a number of vaccines in their platform at that time. And then Seqirus then took this over and produced the from TIV to QIV, and then FDA approved the use of cell seeds, and then finally licensure in the EU, US, and now in Australia. The data is really quite convincing. The HA antibody response in children and adults is quite good, and this meets the criteria for immunological non-inferiority between QIV and the TIV. Efficacy in adults 18 to 49, this is a bit of an older paper of 2010, but it did show at that time 83% efficacy, and especially against the H3N2. An adverse event profile was also acceptable, in fact, quite good. So between the QIVC and controls in children 2 to 18, a very acceptable profile, as it was also in adults over the age of 18. Here it is against TIV, and you can see no serious adverse reactions were recorded. So all that is very good news. On the basis of all that, and much more, I'm sure, they acquired registration, EU and Australia now, and now they've announced, Seqirus CSL have announced a new world-class biotech facility, which you can see on their information on their website. This, I think, will be really excellent for Australia and the region because not only will it guarantee really a large number with cell culture of seasonal flu, but also the switch to pandemic will also be a lot easier, and many more doses of vaccines can be made using pandemic vaccine as well. And I see this really as a very exciting and important step, a very small step, I suppose, on the way towards universal vaccines. But I think having a cell culture platform is the first time really that we've been easily able to move away from eggs, not discounting the fact we also have protein expression with the flu block vaccine. So just to finish with 2 more slides. These are the potential advantages for cell-based vaccines. This is shorter production time, improved process control, the lack of dependence on eggs, and the potential for increased output. Closed systems, which lowers the risk of contamination, and things like antibiotics and preservatives are not needed. Are there any drawbacks? It will be more expensive. So that's one drawback. I think the other drawback is we mustn't lose sight of eggs completely. I think there'll be a variety of platforms needed, and for developing countries, low and middle income, they can probably only afford egg at this stage, but it does highlight the possibility of tech transfer, and this might be possible from in terms of public-private partnerships, as has been done with the WHO GAP program with about 6 developing country manufacturers. So hopefully they can also be done with cell culture vaccines. I think the cell culture vaccine does solve the egg adaptation issue. It will likely offer greater VE, but that still needs to be proven, but it's certainly heading in the right direction. And for H3N2, it does look very good. Cell vaccines will lead to better strain selection because it might be possible for the cell base to make decisions a little bit later than the current time because of the lead-in to manufacture is a bit shorter, and it could be transferred to developing countries. That, of course, would require investment and expense to this expense to the consumer, and we still need our egg vaccines. So thank you very much. And I particularly like to thank these people and their organisations for a number of slides and information. Thank you, Lou.
Hey, Gary, thank you. That was terrific. Our last talk for the day is from Professor Tony Korman. Tony's an ID physician and Director of Microbiology at Monash Health. And Tony's going to talk to us about pneumococcal disease, including changes to the NIP. Tony, welcome.
Thanks very much, Lou. Thank you to the organisers for another excellent meeting, and also for inviting me to come back to speak about a bacteria rather than a virus. I am a member of ATAGI, but this talk will not be directly from ATAGI. I came across this interesting paper in which some investigators in southern Denmark found what was some sort of ancient chewing gum, chewed birch pitch. And from there, they're able to elucidate the human genome and also the microbiome. And it did seem to resemble what we know of the modern oral microbiome, which contained many bacteria, including Streptococcus pneumoniae, in which they were able to reconstruct a genome and show that we've been dealing with this foe for millennia. I'm going to talk about pneumococcal. I'm going to introduce pneumococcal disease and pneumococcal vaccines, and then go on to address my brief of changes to the National Immunisation Program, COVID-19, and pneumococcal disease, and some future developments. We have divided pneumococcal disease into non-invasive disease such as sinusitis, bronchitis, otitis media, and invasive disease including bacteremia, meningitis. If you look at all of community-acquired pneumonia, pneumococcal pneumonia is a substantial cause of of community-acquired pneumonia, and invasive pneumococcal diseases with bacteremia is a subset of that. I think it's compulsory to mention this paper when talking about pneumococcal disease. This is a landmark paper from 1964 from Robert Austrian at the Boston City Hospital, and this shows the pretty drastic natural history of bacteremic pneumococcal pneumonia. You can see here less than 20% of people survived. Penicillin was a real game changer with survival of almost 90% of people who were treated with penicillin. Before penicillin was available, serotherapy with convalescent plasma was used, and Steve Tong talked about that being resurrected for treatment of COVID. And it did have a reasonable effect actually on reducing mortality. But any of the treatments, unfortunately, did not affect the mortality in the first critical 5 days after admission. And you could say, well, maybe this is related to lack of modern critical care. But a more recent study performed this millennia still showed that about 2/3 of deaths occurred within that first 3 days after a positive blood culture with pneumococcus. So I suppose a bit like COVID, I think treatment is hard and prevention is much better. And vaccines is the way we can prevent pneumococcal disease. The vaccines we have available are the Polysaccharide Vaccine and Conjugate vaccines. The Polysaccharide Vaccine contains 23 of the most frequent or virulent capsular serotypes of Streptococcus pneumoniae. In terms of its efficacy and effectiveness, it has caused a significant reduction in invasive pneumococcal disease in randomized controlled trials, about 75% efficacy, and in non-randomized controlled trials, about almost 50% effective in reducing invasive pneumococcal disease, less impressive at reducing all-cause pneumonia, in particular in patients with chronic illness. A recent review by Mike Niederman reinforced these concepts, and again emphasising that protection may be lower with the pneumococcal polysaccharide vaccine in older adults, in those who have underlying conditions such as pulmonary disease and who've been vaccinated more than 5 years before the disease onset. The development of conjugate vaccines took the polysaccharide molecule and linked it to a protein carrier, which led to improvement young infants, the polysaccharide vaccine was not effective, but the conjugate vaccines are immunogenic in that group. They also stimulate mucosal antibodies and memory B cells and lead to reduced asymptomatic nasopharyngeal colonization and reduced transmission of vaccine-type pneumococci. The first conjugate vaccine widely used in the market was a 7-valent conjugate vaccine, and this was introduced around the turn of the millennia in the US. And you can see in the red here quite marked reductions in invasive pneumococcal disease in the underage group who received the vaccine, but also pleasingly in the green line here, you can see reductions in the over 65 group who weren't vaccinated. There was also a reduction in pneumococcal, in pneumonia and hospitalizations due to pneumonia, in particular in the older age groups over 75 and in particular over 85. But there was concern with slight increases in pneumococci, which are not part of the 7 serotypes included in the vaccine, in particular in 19A. And so the development of the 13-valent vaccine with 6 extra serotypes added. And this slide is from the US. It looks, you can see the introduction of PCV7 at around 2000, and around 2010, when the 13-valent vaccine was given to all infants, it's caused a significant reduction in all invasive pneumococcal disease in adults again. And then this was introduced to adults age 65 in around 2014. A nice benefit was also significant reductions in antimicrobial non-susceptible invasive pneumococcal disease after the introduction of the vaccine. In terms of use in adults, the Capita study was a landmark study here, an incredible effort randomizing 85,000 older adults in the Netherlands to either receive PCV13 or placebo and then be intensively followed for suspected pneumonia or invasive pneumococcal disease. And in terms of the endpoint, the first episode of confirmed vaccine-type pneumococcal community-acquired pneumonia was significantly reduced, in addition to vaccine-type pneumococcal community-acquired pneumonia, and first episode of vaccine-type invasive pneumococcal disease, lower numbers, but still very effective. And you can see here the this displayed graphically. Pleasingly, follow-up studies have suggested that the antibody titers persist 2 years after the vaccine for all serotypes and regardless of age and comorbidity. And as I mentioned, the US introduced this vaccine in 2014 to adults and then performed a planned evaluation, which was presented in the last year or so. And some of the key questions they asked were the indirect effects from pediatric use on adults, the effects of use we've observed amongst the older adults, and what additional benefits would be expected if the conjugate vaccine was continued. This is some of the data I've showed already, but there was a 9-fold reduction in vaccine type in invasive pneumococcal disease through 2014, and a 3-fold reduction after the introduction in children. Related to indirect adult effects, there were declines in pneumococcal pneumonia, but not in all-cause pneumonia like we'd seen after the introduction of PCV7 I mentioned before. But there'd been really no changes in invasive pneumococcal disease in adults since the introduction of the vaccine in adults. And the serotypes, which were not part of the conjugate vaccine, were now making up the majority of the disease burden. So there wasn't really much in the way of population level impact on mortality, or no change in the case fatality ratio either. And again, no further population level impact on non-invasive or invasive pneumonia since 2014. And the ACIP then had to vote on what they should do, either recommend it, continue to recommend it for everybody, or to no longer recommend it. And they actually chose the middle path, which was to make it a decision, talk to your doctor, but that all adults should continue to receive the polysaccharide vaccine. What can we, that's the US, what can we learn from Europe? Unfortunately, not much. It's very confusing. If you look at guidelines across Europe, there's a lot of differences in the age of starting vaccination, whether or not there's an upper age limit of vaccination, the vaccine type, whether it's conjugate vaccine, polysaccharide vaccine, or both. And if you recommend both, which ones are recommended first? So it's really quite confusing. Whether a booster is required as well, or recommended. And then for patients who have, or people who have underlying risk factors, very all over the place recommendations depending on the country where you're at. So not much help there. In Australia, just in terms of history, we used the polysaccharide vaccine for many years, and it was funded for all adults aged 65 in the National Immunisation Program from 2005, along with the first introduction of the conjugate vaccine in infants, followed by the introduction in 2011 of the 13-valent conjugate vaccine in all infants. And after a number of years, and I went through this in my talk last year, the decision was made from July 2020 for all adults aged 70 and over to receive the conjugate vaccine alone. But individuals with certain risk factors would receive that along with the polysaccharide vaccine. So the recommendations are here, and really for non-Indigenous adults, it's pretty simple. It's just the conjugate vaccine, one dose age 70. For those with risk conditions, they receive the conjugate vaccine, followed by the polysaccharide vaccine, and recommendations to receive that every 5 years. This paper from Rob Menzies and colleagues was published this year in Vaccine. It's very important to note that rates of invasive pneumococcal disease are still much higher in the Indigenous population compared to the non-Indigenous population at all ages. In terms of the impact, you can see here, both in the older age groups, after the introduction of the conjugate vaccine, there was a reduction in the rates of invasive pneumococcal disease. And then after the introduction of the 13-valent, also further reductions. However, you can see with the light green bars here, I'm trying to highlight that there has been an increase in the invasive pneumococcal disease caused by serotypes which are in the 23-valent polysaccharide vaccine, but not in the conjugate vaccine. And in particular, serotype 3, and looking at it in another way, in Indigenous populations, similar patterns, but much higher rates, unfortunately, still. But in more detail, or seen in a different way here, if you see the green bars, that's increased number of cases due to serotypes in the polysaccharide vaccine, and in the pink is serotype 3, which is, although it's contained in the conjugate vaccine, doesn't work as well as against the other serotypes. And so the authors here have suggested there's a potential benefit in increasing polysaccharide coverage with the polysaccharide vaccine in Australia. So just in the last couple of minutes, moving to COVID, and certainly concern about threats of secondary bacterial infection, such as with influenza. But in fact, some early data from both Singapore here and also from Taiwan suggest a decline in invasive pneumococcal disease in the early months after COVID compared to previous years, which is an interesting finding and possibly might have something to do with non-pharmacological interventions such as social distancing. In the UK also, this paper has looked at the impact of COVID on invasive pneumococcal disease, and again, actually lower disease in the 2020 year compared to previous years, which is interesting. It's also led to increased interest in vaccination. This is just Google searches for flu vaccine or pneumonia vaccine after the development of COVID. So there's a somewhat of a silver lining for that. And of course, we've heard about the huge advances in vaccinology, which have borne fruit with already the introduction of safe and effective COVID-19 vaccines. And I won't go through this, but this may have implications for not just for COVID, but for other illnesses as well in vaccine development. Antimicrobial resistance, a lot written on this, but again, no data. People are concerned about resistance. People question, will it have an impact? Yes, it will. No, it won't. And we'll wait for some evidence. But whatever the data will show, certainly vaccines, including pneumococcal vaccine, will have a major role in trying to reduce antimicrobial use and preventing antimicrobial resistance. And just finally, some future developments. This is a paper from France looking at the 17 years of data. And you can see here, in all age groups, there's been a slight uptick in the numbers of cases of invasive pneumococcal disease. And again, this is related to serotypes that are not contained in the conjugate vaccine. So there's developments with a 15-valent vaccine, a 20-valent vaccine, and even a 24-valent vaccine, which are in varying levels of development. So the PCV15 contains these two, PCV20 contains another 5, and then PCV24 contains all of the serotypes that are contained in the 23-valent polysaccharide vaccine. There's already some good safety, tolerability, and immunogenicity data for the 20-valent vaccine. So that's coming along very well. The 24-valent vaccine is in for earlier stages. And can we make better vaccines? I think there's ways of looking at population genomics to improve this. I don't have time to go through that, but it's a very interesting paper. And then trying to actually understand how the pneumococcus evolves and adapts during natural colonization. This extraordinary study from Africa in young infants, trying to further elucidate how, trying to understand better how pneumococcus colonizes and try and provide benefits for us in understanding the disease and maybe vaccination. And another study, again, looking at the difference between people who become colonized and non-colonized. This is in an experimental human model. So still a lot to learn and a lot to improve pneumococcal vaccination. And I'll stop there, and thanks for your attention.
Tony, terrific. Thank you. Tony's last 5-10 minutes actually took the words out of my first question, which was going to be to Bill, but I think all panelists, and this issue of secondary bacterial infection, which is a prominent feature of influenza, but is it or is it not a prominent feature of COVID? So Bill, do you want to start, and then other people can talk about it? And if there's a difference, why is there a difference? Is it social distancing, or is it an inherent biological difference?
If you're talking in the individual patient, where we see pneumococcal vaccination following pneumococcal infection following influenza infection, we're not seeing that in COVID as far as I'm aware, and it's certainly not in literature, and it's certainly not in my clinical experience. Why is a really good question. I presume it's related to the sort of pathophysiology of COVID with heavy inflammatory markers and heavy inflammation associated with an innate response. That's a virologist's view of immunology, so very kind of messy. Why does it occur specifically in influenza? I'm aware that people have sort of studied it, but I've never seen a definitive answer to that. Thanks.
Would anyone else like to comment? There are experiments in ferrets in influenza showing a reduction in innate responses for 3 to 6 months, and possibly this happens in adults. Would anyone else like to contribute to why people post-COVID seem to be less influenced by bacterial secondary infection? Tony, do you have?
Probably say, Lou, that I think we need to wait for further. These were quite early data, and it's about invasive pneumococcal disease as opposed to pneumonia. So I really couldn't find all that much definitive on. I mean, you can find organisms in people who are in ICU, but we don't really know whether the secondary bacterial infection would be. It does not appear to be, as Bill said, as prevalent as maybe we thought it might be.
Thank you. Ian, I was going to ask you to expand on why there doesn't seem to be as much influenza around, worldwide, and not necessarily just in countries where there's been successful social distancing, quarantining, etc.
Well, that is the $64 million question, as you well know, Lou. I think, look, we can speculate. I think, the rules for global circulation for influenza will be rewritten after this, and maybe we will learn more about how actually things move around. We've done studies here in Australia where we look for viruses which have a little bit of a break over summer and reappear, and we've seen those in the past, so it's surprising some of those haven't cropped up. In other countries, there has to be some underlying cause. And even though some countries probably haven't done social distancing to the same extent that we've done here in Australia and other countries, I'm sure it has had some effect along those lines. And the other one, I think, is global circulation. So shutting down of borders and international travel, I think, has contributed immensely to the circulation of influenza.
Just to ask a really dumb question, but I'm assuming it's not possible the viruses have done a deal. So in history, are there good examples of two different respiratory viruses, not strains, but quite different viruses co-circulating together? Say influenza and RSV or...
Well, yes, no, look, the annual epidemics, that they all seem to get along fine. There are incidences where we get sort of, metapneumovirus seems to come around every couple of years rather than every year. So they seem to find a niche, and it may not be, absolutely the same every year, but, these viruses have certainly found their niche, and Bill might have a better history than I do, but once they're here, they're usually here to stay.
Bill, have you got views?
Yeah, look, I think there's two answers which are possibly a bit off the topic, but one that's really interesting is, why did SARS-CoV-1 not do the same as SARS-CoV-2? Many ways very similar, clearly genetically similar, but that doesn't make everything, but certainly, biologically similar. And the obvious thing for a virologist is the lack of travel, is the lack of direct outbreak, which was, politics aside, China, for both. And yet, we saw with SARS-1 establishment infection in Hong Kong, in Canada, but not in Australia. And yet for SARS-CoV-2, we saw global establishment. And it seems that you can't go past that there's been a difference in travel. And so I guess getting back to Ian's point about, whether social measures and other things have made a difference to influenza, it would seem that would be the most likely, and I guess everybody thinks that. I think the second one about co-circulation, I mean, rhinoviruses is a classic. Exactly as Ian says, it's all about niches, and rhinoviruses have a very particular niche, which is, a low temperature nasal, well, in this case, nasal infection. And we saw with SARS-CoV-2 in our study, 6% rhinoviruses. I mean, there's other studies where it's 30%. And if you look at influenza, it's always rhinoviruses that come up, and they're far more common. So they've been very successful, but they also are successful in coexisting. So I don't know if that answers it, but I think that it gives a perspective.
Thank you. Ian, just the mention of travel and so on, just to clarify with the avian outbreaks, was that migratory birds skipping quarantine, or was that were they local outbreaks?
Like all of the outbreaks to date in Australia concerning high path or even low path avian influenza virus, they're all local. So what happens is these viruses are going along happily in wild birds, don't affect the wild birds, get into the hen house. These viruses replicate where there's a huge opportunity for them to replicate and acquire some changes, and one of those changes turns them from low path to high path, which is very unfortunate for the poultry because it then is highly infectious and kills them all within a couple of days. But they're all local strains. Nobody's skipped immigration. It is what it is, and where you have these events where you can get high amplification of virus like chicken sheds with tens of thousands or hundreds of thousands of birds, it's just something we've got to live with. So biosecurity, very important, even if the Chinese viruses are not getting here.
So is it just science fiction that we could be infected by migratory birds? That human viruses could be imported into Australia, even at a time when we might succeed with human quarantine?
Pretty unlikely, but never say never, I guess. Most of the birds which come here are the waders from the northern hemisphere. They're pretty clean birds, so they're when we look for viruses in them, they're pretty low levels. Ducks are the main contributor to avian influenza, and most of the ducks here in Australia are local ducks. So unless there's something stowing away on a boat or something from China or elsewhere, it's pretty unlikely.
And thank you. Gary, sort of the improvement in cell-based vaccines, is that going to be a sort of a quantum improvement, say better than adjuvants and all that sort of stuff, or is it a stepwise?
I think it's a small step in the right direction, Lou. It's, I think, going to be especially good for the H3N2s, but as I mentioned, there aren't any real definitive studies, but there's certainly, leaning towards cell culture. I think it's a real step forward. And it does seem to eliminate this potential issue of egg-adapted changes, and that can only be a good thing. We need to take these small incremental steps if we're truly interested in making better vaccines, and that involves both things like strain selection and the manufacturing processes if we're going to improve VE. We can't do much about antigenic drift, of course, so they're the only two things at our disposal. So it's good to see all these new vaccines for COVID, which I commented earlier on a Q&A that this will open the door, I think, for influenza, and we should start seeing some mRNA and DNA vaccines for flu now get some serious clinical trials and get to market. And prior to that, there's always been, I think, a little resistance from all quarters, regulators, manufacturers, and even researchers to go down that path, although some work has been done over the years, but it's never gotten to a clinical trial past phase 1 anyway. So I think COVID is certainly going to open that up.
Gary, thank you. Just to finish the session, a little bit of fun, I guess, but Ian's tried to make a prediction for the next 12 months. Ian, I'm offering you and the other panelists another opportunity to make a prediction, anything to do with respiratory infections. And who would have thunk it this time last year? But I noticed Tom Brady has just won another MVP. So, almost anything can happen. Any other prediction, Ian?
No, I think I've given my 2 RSVs back with a vengeance, and flu will be back, but I don't think it'll be 2021.
Okay, thank you. Bill?
I'd agree with that. And my SARS prediction is it'll become like OC43 within the next 2 years.
Thank you. Gary?
Yeah, I agree with both those. I think SARS will end up being a bit of a trivial cold in a couple of years' time. It's a bit of a bold prediction, but that's what I think is going to happen because that happens with most pandemics. And I also worry about complacency. I think complacency will rise, and that might lead to more point source outbreaks that we might see around Australia, apart from the unfortunate quarantine stuff. But I think there'll be complacency, something we've really got to watch.
Thank you. And Tony, you've got the last word.
I prefer not to predict, but Lou, can I ask Gary to comment on mRNA vaccine production? If just one last question, I know that's been a hot mRNA production in Australia. Let's say options for that. I'm sure you'll be able to comment on that, Gary.
Look, it's been very much in the research phase worldwide, really, for influenza. It's certainly been done by various groups, but always been at the research sort of point. I think now with COVID, just to be quite quick, because I think we'll come to the end, it'll be the manufacturers that will take it up, given that there have been some registrations, albeit with conditions or temporary or emergency, but that certainly opens the door, I think, now for mRNA and DNA vaccines for influenza, and we'll see that in the next few years, and I hope we do.
Thank you. Well, I'd like to thank all the speakers, all the panelists. We're now finishing the session, and in fact the whole conference. It's been an extraordinary meeting. I want to thank all the speakers, extraordinary presentations, and the lucky thing is that this has all been recorded and those presentations are available for review. I want to thank Margie Danchin, our co-chair, for a terrific sort of energy that she brought to the program. I want to thank Rob and Steve from PrexHab Productions. So all the electronic stuff behind the scenes has been expertly and seamlessly organised without a single glitch. I want to thank the IC staff, Susie, Jane, Susanna, Silas and Kim. And finally, I'd like to thank our sponsors. And obviously, we can't do this, and we haven't been able to do this for over 30 years, but without strong support. So please give us feedback about your thoughts about this year's meeting. Your feedback and whatever COVID does will be the two determinants of what the meeting will look like next year. I can't predict, but I can see that there's an advantage in at least being partly electronic because it includes a bigger audience. Thanks to everyone and enjoy the rest of your day.